Herkese merhaba. Öncelikle
Hello everyone. First of all, I would like to thank Professor Mücahit for making it possible for us to participate. We are friends for 30 years and I wish that you all have such a friendship. So I would also like to thank him for his contributions to our country, especially as the Turkish Child Psychiatry Society. We are grateful to him. We have esteemed speakers and I am excited. So I'd like to thank Professor Tezen. She's the chair of Ege University Child Psychiatry, Department of Child Psychiatry. So she helps us a lot that it's a cherry on pie for us to publish articles. All our works are based on her efforts. Today we're going to talk about the use of methylphenidate in addictive disorders and disruptive behavior disorders. Professor Gül Karaçetin is an esteemed colleague and friend of mine. So she has undertaken that duty in Turkey and made great strides. And they have recent high-level and significant publications, especially internet addiction and coping with addiction. Her efforts are valuable. Sometimes we are being asked, we're talking about, they say that you are talking about good things. That's why I am working together with good people, good friends. This is my recommendation. So working with people with good vibes, with positive vibes is very advantageous, I believe. Late Attila Turgay lost his life 13 years ago. He is one of the most important child psychiatrists today, and he contributed a lot to the current stage of child psychiatrist. I commemorate him with affection and respect. He always says that use your own data in your speeches, in your presentations. That's why we're going to talk about them. So if you have a data instead of a review, it would be better to submit your own data. Generally, addiction and attention deficits, hyperactivity disorder are closely related. Families sometimes ask, why are we treating it? Well, sometimes we need to tolerate, but they do not know that they are coping with a very difficult disease like addiction, and the biggest treatment is the protective treatment. Otherwise, after addiction is there, its treatment is very difficult. And ADHD, Professor Gül will talk about neurobiology in detail, but they are the dopaminergic deficiency of prefrontal region, and the reward system is disrupted, and the mechanism is the dopaminergic mechanism. And when this reward system is disrupted, there is a need for sudden dopaminergic effect, so they can you do it, and novelty seeking is there in the patients. A regular stimulant is not sufficient. There is a need for a change of adrenaline. That's why addiction is a malus in ADHD. And if ADHD is there, and if there is a substance abuse, there is a 50% of increased risk of ADHD. For adults, the risk is 25%, but the biggest risk is the conditions where ADHD is present with trait disorders or temperament disorders. Suicide risk and sexuality in early ages is increasing. After the substance abuse is there, ADHD findings become more severe. So when these two diseases add to each other, it's not 1 plus 1, 2, but it's like 1 plus 1, 10, 12. Use of stimulants, does it cause it or not? This question is asked for many years and underlined for many years. As a result of using stimulants, any tendency, disposition to addiction, and cocaine and Ritalin have the same effects. They are just presented in the headlines or NIDA's research. The findings are misinterpreted and they same molecules, that's why they cause addiction. And the second issue is the abuse of stimulants. Both there is an alcoholic abuse, and when we administer a stimulant, will it be abused or not? There is a perfect study from 2023. Timothy Willens is there from Psychopharmacology at Harvard. It's a comprehensive work. Use of stimulants. There is an increased use of stimulants. So there is a huge increase in Turkey. The number of child psychiatrists is increasing. Scientific meetings, congresses are increasing. So people are more aware, and it's normal to treat and to use treatment medication. But is it used properly? And how about the illegal use? For instance, for university exams or for specialty in medical training exams, people may choose to use them, which can become problematic. ADHD substance abuse risk is higher. I don't want to bore you with literature. ADHD and in the future, when there is a concomitant behavioral disorders, the risk increases. And if the behavioral disorder is manifested, it means that this is urgent and should be treated. However, in ADHD, if it is alone, it can be divided into two. When attention deficit subtype, anxiety and depression, and there is low risk of substance abuse. However, in mixed type, the risk is even higher. The use of stimulants in the Northern America there are another issue. These are not related to stimulant, but methamphetamine and cocaine. As a result of methamphetamine, the deaths are there, they're observed. What about the factors and early onset stimulant use? Is it a protective mechanism or not? This is conducted on a huge group. 150,000 is the number of samples, and they have substance abuse and stimulant abuse and the frequency of such abuses. Cocaine and methamphetamine, the risk rates, if stimulant therapy is started at a late age, is found to be higher. And if stimulant therapy is started at an early age and lasted for a long time, then the rate is found to be close to normal population, no significant difference. This is in compliance with the Harvard Group articles published in 1996-1997. Normal population treated ADHD, they are similar, no statistical difference. However, non-treated hyperactivity, odds ratio was found to be 3.5 by Harvard Group. And early age non-stimulant therapy is protection against later age amphetamine abuse or substance abuse. Although the sample size is very big, it's not sufficient to make a comment on non-stimulants. So in the future, it should be replicated. But the clear finding is that use of stimulants at an early age and prolonged use of stimulants reduces the substance abuse and stimulant abuse risk. How about the early age? What the age should be? Age should be like 9, 10. Treatments after the age of 9 or 10 is a red line, because every year the power of preventive treatment is getting low. For instance, the treatment was, if the treatment starts at high school age, will it become an illegal use? Will it be abused, or will they give it to their friends? We should be very careful. So starting stimulants at a later age, using it intermittently is a problem, has always been a problem. Late onset or starting at a later age is a huge risk for abuse, substance abuse. We should be careful. For a long time, I've been working on this field, and Gül will also show us the relapse works on alcoholic addicts. So if there is a substance abuse disorder related to ADHD, the time between substance abuse to addiction is very short. In a normal clinic, for instance, in a university, alcoholic abuse or substance abuse, most of the patients are between 34-40. However, if we see a patient at the age of 23-24 who is very active, who is moving all the time, the hyperactivity risk was higher. So use of multiple substances or a drug abuse and alcohol abuse, if they are together, the risk is increasing and the suicide risk is higher and relapse rate. Kaplan-Meier's survival analysis was used by us, and relapse was found to be more frequent, and their maintaining the treatment is low. Their maintenance level is low. It's like starting doing sports and quitting immediately, or starting reading a book and quitting immediately. That was the case in these cases. Mixed type is the biggest risk factor. When the cases are mixed type, when compared to attention disorder, they develop oppositional defiant disorder. So in the mixed type, the risk of tobacco or alcohol abuse are higher. And the signs of substance abuse disorder may mimic ADHD. So the anamnesis is very important. If these two disorders are there together, then the progression is very bad, is very poor. So ADHD should be treated. As I stated, there is a disruption in the brain reward system, and when they wait for a reward immediately, so smoking immediately is more important for them to become a lawyer, a physician in the future, and the stratum and prefrontal cortex are involved. Gül is going to develop on them in detail. So, stable release of dopamine. Well, speedy dopamine flow is like firing of dopamine, and substances can mimic that firing. That's why when the patient is introduced to the substance, then we are done, because the substance, I mean, its cure in attention disorder, improvement in attention is quite risky for us when the child is introduced to the substance. In ADHD, if not treated properly, there are various risks, but recently there is a consensus that it shortens lifespan by 8 years. It might be due to poor nutrition or increased suicide risk, or there are countless reasons. There is a New York trial which lasted a long time. Javier Castellanos and Samuel Cortis did brain imaging after 35 years. After 35 years, the lost case was higher in hyperactivity group, and well, obesity, which they cannot undertake MRI, was high in ADHD. So the guidelines is there. Methylphenidate is the first line option. If not available, other drugs are used. And 3 guidelines were published, an expert opinion, and in 2022, Detect, Nesin Dilbaz from adult psychiatrist. The first option is methylphenidate, and all across the world, the guidelines say this. And long-acting methylphenidate, why? Because abuse risk is lower. There is efficiency throughout the day and no stigma. And drug vacation or should not be given because the refreshment impact, they talk about refreshment impact, but I know that in the summers there are more bicycle accidents and wrong choice of friends, unnecessary sexuality. So it's, I think that if there is no significant cause, stopping a drug for a specific period, for summers, let's say, is not good. I love long-acting methylphenidate. However, side effects of starting a low dose, it's very classical. With short-acting stimulant and then long-acting stimulant to cover the whole day. For instance, if Consenidat or Concerta is used, in the morning 36, in the afternoon there are university exams or high school exams. After 4 or 5 p.m., methylphenidate, short-acting methylphenidate, is a very good option. And the difference between two drugs, the change between methylphenidate and oros, like a refreshment effect. It's like the pharmacokinetics are the same. If we are to start a long-acting one. If the family is capable of managing it very well, child is capable of managing very well, let's start with a low dose. So if the dose to be administered is 36, starting with 18, and if 54, starting with 27, would be a good option. Thank you very much for your attention. Thank you very much, Professor Eyüp Sabri Ercan and Professor Mücahit Öztürk. Meeting with them and being their student, it was a turning point in my life, in my profession. So if our profession is like a relationship between the master and the apprentice, I can say that they are my greatest masters. What I have learned from them is what I have learned, or the everything I have learned about child psychiatry. So I'm a bit excited because I am giving that presentation in front of these professors. And I'd like to thank my residents and the whole Bakırköy team, because I'm going to present some data, and this data was derived from the thesis of the residents at Bakırköy Mental Hospital. We have an internet addiction clinic, and Professor Mücahit provides a huge support through scholarships of Turkish Green Crescent Society. I am excited because I am working together with a professor who foreseen everything 20 years ago. In 2003, Professor Eyüp published a work showing correlation between attention deficit and substance abuse. Why are we talking about behavioral addiction? We know that it is a risk factor, and do we need to talk about behavioral addiction? Well, if there is a branch that can talk about it, is the child psychiatry, because it's a critical period for children, behavioral addiction, and it's a very critical period within our intervention. As mentioned, Professor Eyüp, there is a reward pathway. So for 6 months, the child should work hard, they get a scorecard, or they participate in sports activities and get a reward in the end. But pressing the keys while playing a computer game activates that reward pathway. So just like it activates, it is activated in substance abuse. The difference of behavioral addiction from chemical addiction, and what is its importance in terms of intervention. So we never say that cocaine, we're not talking about healthy and conscious use of cocaine. However, technology, internet games, we're talking about their conscious use. Why is that? Because behavioral addiction is developed in cascades. It starts with the healthy use, used for the needs. So currently in this age, there are lots of homeworks, duties that are done by using internet, and then frequent and regular internet use. The first two steps are called as healthy and conscious use of internet, and in treatment what we are trying to do is to convert children or to get children to the frequent and regular internet use. But the third stage is the problematic internet use. It's not in the addiction level yet. However, internet games or internet starts creating problems in children's lives. And internet addiction is the last stage, or according to WHO's classification, behavioral addiction. This is the last stage. And how it should be called, named, and scientifically, when we have a look at the literature, what is the classification? Let's have a look at it. For the first time in 1996, Goldberg revised substance addiction scales, and Young revised the scales of pathological gambling, and they started talking about internet addiction. And later on, from Korea, from Japan, we see works studies, and the DSM-5 working group stated that this is a huge risk for adolescents, for children, and there is a need for further work, further efforts, and it should be added to DSM-5. And in 2018, it is called as internet gaming disorder. So for 5 years, significant discussions were made, and I also participated in those discussions through Professor Mücahit. And recently in 2018, with ICD-11, WHO recognized this and called it as behavioral addiction, divided into two: gaming disorder and gambling disorder. These discussions and the change in posology is that the works have shown that addiction is not internet addiction. It's the content where the addiction is. Internet is used as a tool, and through internet, via internet, they access to certain content, to games, to gambling, etc. Through internet, it's like content addiction. So nosologically, WHO called it as behavioral disorder, and previously in DSM-5, internet gaming disorder is the subtype of gaming disorder according to WHO. On ICD-11 is there. In 2018, World Health Organization published it. You can see addictive behaviors, gambling addiction, and gaming addiction. Gaming addiction is divided into online and offline. WHO actually made it easier for physicians to make diagnosis. In 2003, the American Society of Psychiatrists, there were more criteria. However, physicians should look at three criteria according to WHO, and if these three criteria exist, they should accept that there is addiction. Loss of control is one of them, and the priority of that behavior over all other behaviors, and its continuation due to unwanted or adverse outcomes. Loss of control, there are many studies comparing them, but I'm gonna briefly talk about which DSM-5 criteria corresponds to which ICD criteria. Loss of control. What is meant by loss of control by WHO, as explained by Professor Eyüp recently? Happiness is only achieved by pressing on the keypad. Mesolimbic pathway stimulation with dopamine, so the child cannot get joy or doesn't feel any joy from any other thing. That's why they want to start that game, to continue that game, to adjust the content, to adjust the game. They lose control. DSM-5 calls it as patience tolerance. So they spend more time with internet gaming, and they are attracted to, and there are withdrawal symptoms like anger or unhappiness, and the failure of attempts to control internet addiction. Priority is an important criterion when the child comes to us, to our office. If the family says us that, doctor, dear doctor, my child is not interested in any other thing in life. One of the mothers of our patients stated that this is above any classification system. For my child, all the colors of life have faded. For my child, it was a very striking example. So this behavior becomes a priority. I mean, gaming behavior becomes a priority, but DSM-5 considers this as over actually excessive mental
ve bir sonraki oyunu bekliyor olması ve diğer alan
occupation, and there is a loss of interest to other fields of life.
birinci ve iki
The third one is actually like the outcome of the first and the second. The first one, second one. The first one is loss of control, and the other one is priority. And the joy from life, despite the negative outcomes, they continue playing these games, and they continue overplaying internet games. And we know that in all psychiatric disorders, we have lack of functionality, impairment of functionality. And DSM-5 also adds two other items. The first one is the time about lying about the time you spend on the internet playing games, or to use the internet games to reduce the negative mood and to get rid of this mood. So we need to have these items on our list. Before the treatment, I would like to talk about the prevalence. This was a meta-analysis from 2022, and the gaming prevalence, gaming disorder prevalence is 3.3% around the world, and it is compliant with the previous studies because it was between 1.3 to 0.3 to 5.9. However, in South Korea or Japan or in the Asian countries, it's much higher. In the US, it is at the peak level, and in Europe at the moderate level. In our country, we see that this disorder prevalence increases by time, especially the behavioral gaming disorder reach 1.6% in our country. Why are we talking about this as the child and adolescent psychiatrist? Because this prevalence for the teenagers or the adolescents is 8.8%. It's a very important period of life, and ADHD is also another important outcome of this disorder. Why are we working on the risk factors, and why are we focusing on addictive behaviors? It's because sometimes the patients come to us and their families tell us that, doctor, it is much better for him or her to play computer games instead of going out and facing a danger outside. And this is not the case, unfortunately, because this addiction actually causes a huge loss in their lives. And this is Melike Topal's thesis from our clinic. And the children with addictive behaviors, we see that in those children, they drop out of school. The frequency of dropping out of school is very high, and dropping out of school also is highly correlated with drug abuse or substance abuse. And as mentioned by the previous speaker very clearly, we always focus on preventing addiction. I mean, everything about addiction research is focusing on prevention before it develops. How can we prevent it? We know that prevention or preventive measures are focusing on the risk factors, try to reduce them, and also enhance the protective factors. Since 2016, we have an internet addiction polyclinic, and at this polyclinic, we see that each child with ADHD is not addictive or addicted, or each isolated, alone, lonely child is not addicted. There could be multiple risk factors in some children, and all these underlying factors come together with other factors such as new platforms on the internet and some misconceptions about internet indicating that it reduces their distress. So we should understand all these risk factors very well, because we focus on loneliness and weak bonds within the family and incompetent parents. However, we can intervene in ADHD and social phobia and also other problems that we can address. And in our observations later on, we have seen that from problematic use to the addictive behavior, there are some factors in between we should focus on. And we carried out a thesis study about this, and here you can see that internet gaming disorder and problematic internet use, the links between cyberbullying, aggression, loneliness, and psychiatric comorbidities. And when we look at the children who were diagnosed with the internet gaming disorder and also those with problematic internet use, there are some factors that differ in these two groups. I mean, these could be the cyberbullying and other issues. And when we compare internet gaming disorder and other psychiatric comorbidities, we see that the comorbidity, in terms of comorbidity, ADHD is the most relevant, the most important one. And attention deficit and hyperactivity disorder is the main factor here. How does it cause internet gaming disorder? Because there is hypodopaminergic activity, and also there is the avoiding and award-seeking behavior. There is an insensitivity about this. So these are the common characteristics of such children. And according to the studies conducted when compared to the control arm in the individuals who are addicted to gaming, orbitofrontal cortex, nucleus accumbens, cingulate and medial frontal cortexes and prefrontal cortexes and caudate nucleus have activation in the MRI. So this also shows us that these are the areas which have hypodopaminergic activity in ADHD, and these areas are activated when they are playing a game. So it shows the close correlation between the internet gaming disorder and ADHD. So it's kind of a substance use mechanism behind it. There are also other studies that focus on ADHD and also impulsivity. And according to a very recent study on children, it was compared, I mean, the children compared the ADHD and also healthy control children were compared, and in the healthy control group there was an internet gaming disorder by 9.5%, and ADHD cases should be classified in two groups with or without internet gaming disorder, it was found out that internet gaming disorder plus ADHD causes more lack of functionality, and there is more internalizing effects, and there is more social exclusion or social isolation. This is another meta-analysis from 2022, and 7 meta-analyses actually were evaluated in this, and it was emphasized that this is of all interaction, because we know that internet gaming disorder is a risk factor for ADHD, and ADHD also is affecting the children and causing internet gaming disorder. In early childhood, when we have the problematic gaming behavior, it may lead to a higher level of ADHD symptoms. And I will not go into the details of all these studies in this meta-analysis, but there are some important findings I would like to highlight. In all these studies, repetitively, internet gaming disorder symptoms and ADHD, anxiety, depression, objection, and behavioral disorders are correlated, and many of the studies actually confirm this correlation. When we look at the cases with ADHD and internet gaming disorder, we see that when compared to the non-comorbidity cases, these children have some emotional regulation problems. They have disruptive emotional problems, and some studies tell us that hyperactive, impulsive, combined type is more common. However, in some of the studies, it is said that hyperactivity and impulsivity alone can be more common. In girls, we see addiction of mobile phones, and boys, we see internet gaming addiction. We can actually reduce the ADHD symptoms if we control the internet gaming disorder. So if we summarize it, this is a two-way street, and we know that ADHD causes lack of attention, impulsivity, self-control problems, some getting bored easily, and cannot deal with the postponement of the award, and we also see that there is emotional regulation disorder in ADHD around 4.6 to 44%, and we know that internet gaming disorder can worsen the ADHD symptoms, and ADHD prevalence is 19.5 to 100% for the internet gaming disorder children, according to some studies. When it comes to the treatment, if we treat ADHD, we can see some improvement in internet gaming disorder. If we cannot prevent this, and if we couldn't prevent this, and if this occurred, then we should start therapy, we should start treatment, so that these children can find their way to a better and healthier use of internet. And 86 adolescents were evaluated in this study. 44 of them received MPH, and 42 of them received ATM, methylphenidate, and atomoxetine. And in both groups, there is a significant reduction in impulsivity, both in behavioral inhibition and activation scales. And we saw that there is a correlation between the two, especially for the MPH. According to the Korean scale, there is a reduction in ADHD symptoms. And again, there is another study from 2009. Oral methylphenidate was used in the study, and after this treatment, both in the internet addiction and ADHD scores were reduced. And in 2023, there was a review. all the studies conducted so far were reviewed in South Korea between 2012 and 2018. 8 adult, 4 child and adolescent studies were included, and 76% is the amount of at least one psychiatric comorbidity. I have limited time, so I'm just skipping these parts. And what I would like to tell you is that the ADHD and internet gaming disorder, ADHD is a very important predictive factor in terms of internet gaming disorder and its persistence. Because if you do not treat it, the child will continue to play more and more, and fecolon developed in some children because they don't go to the toilet and they just postpone going to the toilet and just use bottles to pee. And what we can tell in conclusion in those studies is that there are some differences in terms of nosology, and WHO clarified it after 2018, and before that DSM measures were used, and it shows us that we should continue to carry out more studies. This is another longitudinal study, and a longitudinal study shows us that it is very highly correlated, and it's very important in terms of prognosis. And I will talk about an fMRI study between the ages 13 and 18. Subjects were enrolled, 26 ADHD, 29 ADHD plus internet gaming disorder, and 20 internet gaming disorder cases, and 40 healthy controls were included. And in all groups, cortical subcortical levels were found lower in all these groups, and cortex and subcortical structures have functional connections, especially in good prognosis cases. So it shows us how important treatment is, and CBT can be added to this therapy according to some meta-analysis, and there are some case reports, and pharmacotherapy plus CBT can be combined according to the child's needs. So in conclusion, I can tell you that we should evaluate each child for himself. Why is this child is here, and what happened, so on and so forth. We should focus on all these questions, and ADHD and behavior issues should be evaluated in all these cases, and we also check for other comorbid psychiatric disorders, and we should prevent and intervene in them. Thank you very much, and we should protect our children before addiction develops. Sorry, I may be a little bit late. Thank you for these presentations. We have Mücahit here with us. Now I'm asking this question to you and to him. ADHD drugs that contain methamphetamine, we prescribe them so often, so much, and we gave them to kids so that they should study their lessons, they should do their homeworks, but there is a very high risk in Turkey where so many patients are using methamphetamine. So we have a very high risk of methamphetamine addiction now today, and we know that these drugs are only given if you have a red prescription, and atomoxetine was not emphasized, so I would like to learn your opinion about atomoxetine. I can start now, and then Mücahit may make additional comments. We use methylphenidate instead of methamphetamine, And lisdexamfetamine, it is a very important drug, and there is no chance of abuse in that drug, and the effect size is very high, 1.2 or 1.3%. So it's a bit expensive. This is why it is not the first option. Adderall is actually similar to those. It's not available in Turkey and in other countries, although it has many side effects and is similar to amphetamine derivatives. It is not proven whether it will have a high level of addiction. And Matkatlar and al. Carried out the study, as I told you, and according to this study, especially if you give methylphenidate before the age of 9 and it goes on for a long period of time, and it may reduce the addiction rate for the stimulants or cocaine or other drugs. And if you do not treat this in such a child, then the addiction rate, potential addiction rate in the future is much higher. In Denmark and Norway, there were other studies conducted, and similarly, if the treatment is given before the age of 10, it is really productive. However, in later ages, methylphenidate use, can it actually cause addiction to some drugs? Like you said, there is no such data and evidence about this. Throughout history, everything started with amphetamine, and then it's shifted to methylphenidate. Why? Because in amphetamine there is an aspect in amphetamine that causes euphoria. So methylphenidate does not cause euphoria. Actually, it reverses the situation. It makes patients anxious and depressive, but there is no such similarity. But I can say that, can methylphenidate be abused psychologically? Yes, because when you have an examination such as specialty examination in medicine or university examination or other examinations, some people may use it without a diagnosis. But with the e-prescription system, digital prescription system, it's not much possible. Only the kids may give these to their friends. But methylphenidate is not mood improving. Actually, on the other hand, it causes patients to be depressive. And there is other routes where the patients may take it, and this applies to all the other drugs. But other than that, there is no such evidence about the addiction with this drug. And NIDA's trials may be misinterpreted because in striatum, when beta-hydroxylase is elevated, it causes euphoria. Methylphenidate, if given orally, does not cause euphoria. As mentioned by Gül, if there is steady release of dopamine, it doesn't trigger or stimulate the award center. And there could be some bursts maybe, and all spec studies show us that, because if you take oral methylphenidate, it doesn't cause such an elevation. But if you give it intravenously or if you sniff it, then it can be problematic. So all the studies tell us that we should start early and get rid of it as soon as possible, because I visit Gül and it's a very dramatic picture. It's very hard to win this game when you are already losing. Atomoxetin, of course, since 2012, we have introduced atomoxetine in Turkey, and I tried to introduce it to all the doctors around the country. It's a very important agent because in 1984 it was found as an antidepressant, and we know that there is this Spencer from Harvard Group. He's a psychopharmacologist, and it shows us the effect of ADHD. So, what should you do? There is no way of abuse of this agent, and in terms of addiction, we can say that when the ADHD is improved, we see a dropped risk of addiction. But sometimes when we are not sure about the family or the patient, we can use atomoxetine. And I was talking to, we will have talks with Mujahid in future sessions, and atypical antipsychotics can be the golden standard, for instance, for if there is a risk for substance abuse. So it affects the impulse mechanism, because with the metabolic side effect, and if you put addiction in against it, they are not the same. Guanfacine also is another important alternative. It has some sedative effect, and it may be protective in this respect. And tamoxifen is also very significant, as you have said. Any other question or comment from the audience? Thank you. Thank you very much for your attention.